Welcome to NWADC Project Echo. I'm Kent Unruh, and I'd like to turn it over to Christian Ramers to introduce our speaker today.
I'm sure you know David Spock, our clinical director at the Northwest AETC, and he's going to talk to us about second-line therapy today. Again, as I mentioned last week, this is really high-yield material, and if you peeked at the slides, and this is going to be an outstanding talk, really one of the essential skills to move into the advanced realm of HIV therapeutics. So, David, take it away.
All right, Ken, Christian, thank you very much. Well, this is a follow-up from last week where we talked about resistance testing, and now what I'd really like to cover is sort of the practical nuts and bolts of what kind of regimens you go to and what kind of approach you take after one of your clients has virologic failure with an initial regimen. Well, again, just to sort of outline the framework of what we're talking about as initial therapy, looking at the HHH recommended guidelines, we have NNRTI-based therapies, protease inhibitor-based therapy, and integrase strand transfer inhibitor-based therapies. So I'll really key in on all three of these classes and what you do when you have virologic failure after using drugs in those classes. I'll focus the most on the top, which is the NNRTI-based failure, because the Efavirenz, Tenofovir-Emtricitabine, or ATRIPLA, is so commonly used now. I think it's worth spending a little extra time focused on that. Well, really what we're getting at here is what do you do after using any of these based regimens in terms of your next failure? I'm not going to go to all the details of every question you want to ask a client, but clearly from the clinic standpoint and clinical standpoint, you want to go back and reassess everything in terms of adherence, lifestyle issues, all of the factors that can come into play in terms of why the patient actually had virologic failure. I'm going to focus not so much on that, but really what to do once this has already occurred from an antiretroviral standpoint. Well, let me start off by presenting a case. This is a 29-year-old woman who has a baseline CD4 count of 285, has a viral load of 94,000, starts on a regimen of Tenofovir-Emtricitabine-Efavirenz, ATRIPLA, very common regimen. After 4 months, she does great. She's got a viral load that has reached undetectable levels, less than 40 copies. She does very well on this regimen for about 10 months. After missing 2 appointments, she comes in for a follow-up visit, admits she had had a relapse with some alcohol problems, but is now sober. Unfortunately, you draw a viral load at this time, and it's now 1,120 copies per milliliter, which is clearly high enough to do a genotype. So the 3 questions I'm really asking is, once this has occurred, what is the treatment goal of second-line therapy? Number 2, what are the mutations that you would likely expect to see on a genotype with this very common regimen? And number 3, what second-line regimens would you recommend if you are going to need to go to a new regimen? So in terms of the goal, the HHH guidelines does not mince words on this at all. With all of our current antiretroviral armamentarium, the goal is clearly, as shown in this graph, reestablish maximal virologic suppression. So in other words, get the patient undetectable again. We used to have goals that were less rigorous in terms of just maintaining CD4 count, but nowadays the goal is clearly virologic suppression. So the second question really is, what mutations would you likely see with an ATRIPLA failure? There are 3 studies that give us a very clear idea of what you're likely to see. Study 934, study ACTG 5142, and the START-Merck study. All of these studies basically say the first mutation that you're likely to see is the mutation known as the K103N. This is the signature mutation for Efavirenz, and it essentially makes Efavirenz completely ineffective. The next mutation that you're likely to see is the M184V or M184I. That's the signature mutation for either lamivudine or emtricitabine. So with ATRIPLA, this would indicate that you will lose activity with emtricitabine. Not complete activity, but you will lose significant activity. You can see as time goes on, if you keep a failing regimen going, you will accumulate multiple other mutations. So one of the first principles in switching is that you want to make the switch as soon as possible so that you do not accumulate mutations and go down a pathway of less and less options in the future. Now this is just a graphic to kind of give you a sense for visually what these type of mutations mean. So looking at the NNRTI drugs, the 4 drugs in the class, Efavirenz, etravirine, nevirapine, and rilpivirine, just giving you sort of a framework and a baseline, That's with wild-type virus. All of these have susceptibility, and the question is, what would you see in terms of a K103N in terms of the impact of that? Well, very clearly, efavirenz and nevirapine are going to move over in the category of high-level resistance. Etravirine and rilpivirine are really affected, not much different than if you had wild-type virus. So they remain active. They don't become hyper-susceptible once you get the K103N. They're just not significantly impacted by the K103N mutation. So that's a visual of what happens with that. Now, what about the impact of the M184V on the nucleoside reverse transcriptase inhibitors? And as you can see, we have a host of drugs in this class. And the question is, what happens to all of these drugs once you develop a M184V or I mutation? And clearly what happens is that you lose significant but not complete activity with emtricitabine and lamivudine. Abacavir and didanosine are slightly impacted, and I will say that if you go on and leave a person on a failing regimen and accumulate more mutations, you can start to have a bigger and bigger impact on abacavir and didanosine. Interestingly, though, with the M184V mutation, you actually develop some hypersusceptibility where the drugs like tenofovir and stavudine and zidovudine actually become more active. So the net impact is you lose something, but you don't lose quite as much as you might think because you have this hypersusceptibility with the so-called thymidine analogs and tenofovir. Now, so practically what does all this mean in terms of options after you fail a triplet? So there is data that would suggest going down on the third bar there that staying within the class and using etravirine and keeping, for example, tenofovir, emtricitabine, and then using etravirine, that option does not look good. There's a study that showed us that you do not get good virologic suppression with that compared to what you would get with the boosted protease inhibitors. In addition, there's some indirect data that we can draw upon called the Switchmark study, where we would imply that keeping the nukes the same and switching to Raltegravir would not be a good idea. So I think what we're really left with is the best options are either to switch to a ritonavir boosted protease inhibitor, and there is some significant data that would suggest you essentially could just keep the Truvada end of this, tenofovir emtricitabine, and go to a top-line ritonavir boosted PI such as ritonavir atazanavir or ritonavir darunavir. You would not need to add in an additional drug, and that was shown from a Canadian study that has not been published yet. The other options are, especially if the person has some renal insufficiency or you're trying to get away from a drug in the NRTI class, you could construct a regimen that has drugs from two other classes. For example, tenofovir, emtricitabine plus Raltegravir, Maraviroc. Or even you could use one nucleoside reverse transcriptase inhibitor and come up with a creative regimen. But the idea here is the standard approach usually would be to go with the top line, which is to use a ritonavir boosted protease inhibitor. And the key point is you probably really don't need to make major changes other than changing out the efavirenz for the ritonavir boosted PI. So one question that comes up, if a patient has failed from a virologic standpoint on a triplet, which is a simple regimen, you really want to keep your next regimen as simple as possible as well. So ritonavir atazanavir is very simple because it's once a day. The question then is, in second-line therapy, if you're going to use darunavir, can you actually use once-a-day darunavir? And I won't go through all the details of this trial except to say this really looked at that exact question. In a failing regimen, could you use darunavir once a day boosted with ritonavir, or do you have to use it twice a day? These were experienced patients. They did not have any darunavir-associated mutations. So they had previous virologic failure, but no darunavir resistance. And this is a study called the ODIN study, and the results basically showed in these type of patients. So for example, someone who failed a triplet, the once-a-day darunavir is just as good as the twice-a-day, and obviously would be better tolerated, more convenient for patients. If you look at all strata of viral loads, all patients, those with baseline lower viral loads, those with baseline high viral load, the BID did not show any advantage over the once-a-day for darunavir, ritonavir. So in general, our practice is that if somebody fails a triplet and you're going to use darunavir as the next regimen, the once-a-day regimen would be fine. Now, what about individuals who fail an initial protease inhibitor-based regimen? This one is really a tough one, because one of the things that happens when you fail a protease-based regimen is that you often don't even see any protease mutations. You just see the 3-TC or emtricitabine 184 mutation. So what are the options here? What should we do? Well, one of the things we know of that if you've got a really highly potent, high genetic barrier of resistance regimen like a boosted PI, going to Raltegravir or an NNRTI-based regimen is probably not going to be a good idea. So really you need to think about a couple of things. First of all, number one, we don't really know what the optimal approach is, but what we do know is that you don't often see PI mutations early. You will if you keep the regimen going and it's failing. So one of the things to do is, because the M184 is often the common mutation that you see, and you haven't often lost huge amount of ground, what you generally want to do as a first thing is to re-examine what's going on. Is the individual not tolerating this? Are they not taking it regularly? These drugs are so potent and have such a high genetic barrier of resistance. That is usually the problem. And sometimes just reinstituting really good adherence can recapture a ritonavir-boosted PI. But nevertheless, if you have failed an initial regimen, especially if it's atazanavir-based regimen, the data would suggest that going to Darunavir in that situation is often very effective because it has a different resistance profile. So my own approach in this is I think you need to individualize. This is one that's often a very good idea to get an expert involved, because PI-based failures are not as simple to manage. But again, the first thing to do is probably go back to the drawing board with adherence, hustle that really good, and then recheck a viral load in about 4 to 5 weeks after that. The second point to make is that if you do run up resistance with Darunavir-based regimen, this is complicated. Or if you've got multiple PI mutations and you're wanting to switch to Darunavir, taking a look at this, you can see that there's a complicated resistance profile with Darunavir, and you should get an expert involved because there are major mutations, minor mutations, and then you can basically score these. And the more that you have in terms of your baseline Darunavir-associated mutations, the poorer response you get. But interestingly, with just 1 or 2, you still generally get a good response. So the take-home point from this is, if you're judging whether or not Darunavir will be active and you have a lot of mutations, get an expert involved for consultations. Now, looking at the last option, what about an individual that fails Raltegravir? Well, this is going to get very interesting as we have new integrase inhibitors rolling out in the future. But what I think we can say with this is the same principles hold with this as it does with Efavirenz or a triplet failures, because Raltegravir is a drug that does not have a real high genetic barrier of resistance similar to Efavirenz. So you want to go to a higher resistance profile drug with higher genetic barrier resistance. So again, I think if you fail Raltegravir, you are very likely to do very well with a ritonavir-boosted protease inhibitor-based regimen. Similarly, though, you could construct 2 new drugs from 2 other classes. For example, you could use ritonavir-boosted PI and Maraviroc and maybe lamivudine. You can get creative here. Now, in the future, what we're expecting to see is more interest in genotyping with Raltegravir, because early you tend to get this 155 mutation, late you tend to get a 148. So the point I want to make with Raltegravir resistance is do not maintain and keep a person on it if it's failing. What this graphic shows you that over time, red is bad. With each visit with continual failure, you stack up more and more mutations. You can see after 3 visits, if you didn't change the person, you've got more mutations. You've got a lot of patients with 3+ mutations. So the take-home point with that is do not keep a patient going on a failing Raltegravir. So what are the key points with this? Resistance to Raltegravir revolves progressively. Avoid prolonged failure. Integrase genotype may be helpful for second-generation use of the newer drugs coming down the road. You often see a M184V before you see Raltegravir resistance. Boosted PI should be effective. Cross-resistance is probably going to be common with Elvategravir. Dolutegravir, a future protease inhibitor, looks great as long as you don't blow it by using the drugs for a long period of time. So just to conclude then, I think our goals are very clear with second-line therapy. Suppress viral load less than 50, avoid prolonged virologic failure, Atripla failures can usually be managed with ritonavir-boosted PIs. Early ritonavir-boosted PI often not associated with PI mutations. Very interesting. And last, the Tenofovir-Emtricitabine-Raltegravir failure can usually be managed with the ritonavir-boosted PI. So I hope that's a bit of a glimpse into some of the second-line therapies that we'd be using. Thank you.